I'm really thrilled to be here. This is my first time presenting at this meeting. I think we've got something exciting to share about some of the work we've been doing with our molecule, ZYN002, which is cannabidiol, or CBD, in a transdermal gel. And I'm going to show you the work we've been doing over the past few years, some phase 2 work that's open label, some phase 3 work where we think that we found what may be a biological marker of therapeutic response. And I'm excited to walk you through this. So let me go ahead and do that. I'm going to do that so I can see my whole slide. Cool. So that's me. My disclaimers. This drug is not approved. So I have to make very clear that that's clear. We are still in the process of development, and I work for the company. So what are we talking about? This year, I think we've all become very familiar with things like Purell, what it feels like, what it smells like. So our product that we hope to bring to the market feels very similar. We dispense it in small packets of a ketchup packet. You open that up, you rub it into your skin and the shoulders twice a day. This is pharmaceutically manufactured. It is not derived from any other substance, and it is pure CBD. So that's some of the background. Again, it's administered on the skin and becomes systemic. If you are familiar with cannabidiol and THC, CBD is what we're talking about here. It is the non-euphoric, the primary non-euphoric component of cannabis. THC is the component of cannabis that is associated with euphoria. Okay, so a little bit of a primer. So there is something called the endocannabinoid system, which is a very old biologically conserved system that has been around for millions of years. This endocannabinoid system, which in humans does function in part as a system that creates stability, certainly a level of homeostasis. This ECS system, the endocannabinoid system, it is a G protein coupled receptor, CB1 and CB2 in the endocannabinoids. The endocannabinoids are your naturally occurring cannabinoids, anandamide and 2-AG. And evidence over many years has indicated that the endocannabinoid system has a very important role in the CNS and behavior. Alterations in experimental animal models result in changes in cognition and behavior. Drugs have been developed in the past that target these receptors to various capacities, including changes in reward, etc. Okay. So here are the 3 programs that I'm going to be talking about, at least the 3 studies rather, that go into our overall development program in ASD. The first study is called BRIGHT. The second is BELIEVE. The third is ConnectFX. The BRIGHT study is an open label phase 2 study in children with ASD. And the key findings were a positive risk-benefit profile when ZYN002, that's our drug, was administered on top of stable standard of care. BELIEVE is another very interesting program. We looked at kids with developmental and encephalopathic epilepsy, or DEE. Now, these are kids who have developmental delay, who also have refractory seizure. And a very significant portion of that population, about a quarter of the kids in this study, maybe a little bit more, also were clinically diagnosed with ASD. And in that group of kids, in the overall population, we showed an improvement in open label in seizures. And I'll describe later what FIAS and TCS are. And in the children who had ASD, again, these are kids with refractory epilepsy who are also co-diagnosed with ASD. We showed important reductions in open label in these seizure types. And then finally, I'm going to present to you data from our phase 3 study in children with FragileX. And you'll recall that FragileX is the most common monogenic origin of ASD. And when we looked at children with very strong methylation of the FMR1 gene, the FMR1 gene is responsible for the production of FMRP. In that group of children, we showed a very strong signal. We didn't show a p-value in the overall population, and we'll talk a little bit about that. So here's what I'm going to talk about. So the first study, again, is BRIGHT. The first author is Dr. Helen Hausler and her team. This was conducted in Brisbane, Australia, Queensland, and we have offices in Australia, which we're certainly involved in, also our offices in just outside of Philadelphia. Okay. So as you all know, ASD, complex, neurodevelopmental, characterized by difficulty with behavior, communication, reciprocal social interaction. And as everyone is aware, there are limitations to the current armamentarium. We believe the endocannabinoid system is a modulator of emotion and social behavior. We also believe it to be dysregulated in ASD. And therefore, our hypothesis was that transdermal CBD might provide therapeutic benefit in ASD. Right? So this was BRIGHT, also by our code name ZYN002CL for clinical study. 030. This was an exploratory single-center open-label phase 2 study looking at safety and tolerability of ZYN002 or CBD in children and adolescents with ASD 4 to 8, less than 18 years of age. Okay. The study enrolled patients with a CGI-I, a severity score of greater than or equal to 4, for moderate or greater burden. The ABC community, the aberrant behavior checklist community, irritability score had to be 18 or over. And that's important because when we go back to studies like the old risperidone trials of the late 1990s, early 2000s, the children who seemed to benefit most were the children with a baseline score of about 18 or better. And the primary objective of the study, evaluating the safety and tolerability of the drug in this group of children for up to 38 weeks. So there was a 14-week treatment period, a 6-month extension period, very typical safety measurements, ECGs, AEs, laboratory tests, etc. Primary efficacy assessments in this study were the ABCC and the CGI. Secondary objectives comprise evaluation of symptoms of ASD, including parental or caregiver stress, so the APSI, looking at parental stress, the autism impact measure, and qualitative caregiver-reported behavioral problems. So we really wanted to listen to the voice of the patient and family. And the children received 250 milligrams or 500 milligrams of the drug based on their weight daily for 14 weeks, in addition to stable standard of care. And this might be antipsychotic agents when prescribed, antidepressants, and other drugs that were given for the treatment of symptoms. Okay. Again, looking at our baseline demographics, the average age is 9.2, more males than females in this particular study. This was conducted in Australia, so we're looking at about 75% white, 5% Indigenous Australian, 8% Indian, and about 11% other. Okay. Here are the baseline disease characteristics. So this was a study that was enriched a bit for severity. Again, how long did the children have symptoms? It's 5 years, and in the previous slide you saw the children were still quite young. So these are children who are having symptoms over about 5 years that are not fully responding to treatment. The mean ABC irritability score, we required 18, but the average was 30. If we look at the PRAS-ASD, and this is a measurement of anxiety, so 24% of the children have scores of at least 52, indicating possible clinical anxiety. So there was a question in the previous presentation about anxiety in these children. And this gives you a sense of how anxious the children are. And we have here the autism impact measure domain scores, and you can see these in atypical behavior, communication, peer interaction, repetitive behavior, and social reciprocity. The children are largely in the moderate to severe group, a little bit more than half of the children having severe symptoms. And when we look at the ADOS-2 comparison score, 94% of the participants have moderate to severe symptoms of ASD. Okay. So here we're looking at now the outcomes. So if we look at week 14, we're looking now at the ABC subscale scores versus baseline. And remember, there's no placebo group. This is open label on top of standard of care. So the kids, they're taking risperidone. This is on top of risperidone. And if we look at irritability, inappropriate speech, stereotypy, social withdrawal, and hyperactivity, we're seeing both good evidence of clinically meaningful response as well as statistically meaningful response or statistically significant response. So we're seeing almost a 40% reduction in irritability. We're seeing about a 40% reduction in inappropriate speech, about a 40% reduction in stereotypy, 35% in social withdrawal, 35% in hyperactivity. So for an open label study with a new drug, it's looking very, very suggestive of something we want to follow up on. So let's go to the next slide. I'll show you some additional information that really looks more now at the voice of the family, and as well as the clinician. So if we look at the parent-rated anxiety scale, we see almost a 46% reduction in measures of anxiety and about a 40% reduction in the level of parenting stress. CGI improvement, it's almost a 60-40 split, with about 57.1% of the families, the patients and physicians seeing an improvement, and about 43% saying, well, not particularly improved. Oops. Okay, so again, now looking at the autism impact measure, again, we're seeing across the board pretty good evidence of response. 34% response, statistically significant in atypical behavior, an improvement in communication of nearly 20%, same for peer interaction, nearly 20%. About a third of the kids, is about a 33% reduction here in repetitive behavior. And then what we like here is this improvement in social reciprocity. Even though the percentage appears to be smaller, it does reach statistical significance. And I think anything that moves in a positive way in social reciprocity is certainly something we want to see more of. Okay, now, if we look at what the caregivers told us at week 14. So we asked the parents to give us examples of what they cared about, what was important to them at baseline in terms of behavioral symptoms, in terms of social symptoms, in terms of emotional symptoms. And across the board here, we're seeing in green improvement. So in behavioral symptoms, about 70%, about 2/3 in social, a little bit of worsening, 3%, and in emotional, again, about 70% of parents said there was improvement. And what were they saying was improved in terms of behavioral? Aggressive behavior, refusing to go to school, repetitive phrases, self-harm, social, minimal social engagement, no personal space, no empathy for others, fear of new people, and then emotional, anxious, little regulation of emotions, and easily offended. And again, open label, but we're looking at some pretty big improvements in what the parents are saying in behavioral, social, and emotional domains that at baseline they were most concerned about. So this is another way of saying, what do you care about, and did it get better? Okay, so to review, this particular study, and I'm going to start here in the upper right-hand corner. The primary efficacy measures, we looked at the ABCC, improvements in irritability, inappropriate speech, stereotypy, and social withdrawal. Reductions in the parent-rated scale of anxiety, mean improvement about 46%. Parental stress, an improvement of almost 40%. Looking at the autism impact measure, Again, improvements in the range from 10.7% to up to 34%, all with good statistical significance. And then we asked caregivers, did you see improvements in behavioral, social, and emotional domains? And the answer is about 2/3 of patients families saw those improvements there, or that level of increase of 67, rather 69, 63, and 72%. Okay. So we have to also talk about safety with a new drug. There were treatment emergent adverse events. These were all mild or moderate. They were reported in about half of the patients. Treatment-related events, which are related, the physician is saying, I think these could have been related to the treatment. Those only happened in 14% of kids, and these were mild or transient. And there were no serious or severe AEs or clinically significant changes in laboratory tests. And you can see this displayed here in this table. And so our conclusions are, for 14 weeks of treatment in ASD, we see something that suggests a positive benefit risk profile for this drug when administered in addition to stable standard of care in kids with moderate to severe ASD. Improvement in ASD in the measures that we use, the ABC, the AIM, the PRAS-ASD, the CGI, and the qualitative caregiver assessments. And we think that further controlled studies are warranted. So that's the first study. Let me go to the next. This is the BELIEVE trial I just told you about. The primary investigator here was Ingrid Scheffer from Victoria, Australia. And let me jump ahead. So DEEs, as I explained, this is a severe group of neurodevelopmental disorders characterized by seizures, abnormal EEG, and these negatively impact development. DEEs include, but are not limited to, West syndrome, Lennox-Gastaut syndrome, and Dravet. DEEs with an onset of less than or equal to 18 months have an incidence of about 1 in 2,000 births. The seizures are quite generally refractory to anti-seizure medications. And sometimes oral drugs in this population can be difficult, behavioral and cognitive impairments, etc. These children are quite medically fragile, and ASD, sleep disturbance, are comorbid and can further increase disability. So here's our study design. We're going to show you the data through the first 12 of the 18 months of the study. Open label, 2 centers, multiple dose, phase 2 study in patients between age 3 and less than 18 years of age with DEE. There's screening, baseline, titration, and dosing. Again, this is a population where the age is about 10. Here is about even males and females. You can see that the seizure types are focal impaired awareness, tonic-clonic, generalized, and focal. And we see that about 30% of the children have autism spectrum disorder. And among the kids with autism spectrum disorder who have seizures, there's focal impaired awareness, there's tonic-clonic, generalized tonic-clonic, and focal to bilateral. And the mean number of anti-seizure drugs each child is taking is almost 3, it's 2.7. So when we look at meaningful reductions in seizure frequency, and we count these over 28 days, and we should look at the improvement from baseline. We show an improvement at baseline at month 3 of 44% in all the patients. We see a reduction of 51%, 60%, and 73% up to 1 month. The numbers decrease because we have fewer kids that have completed the study at the end. And when we look at the children with comorbid ASD, we're seeing 45, 59, 67, and 74, which reflects what we see in the overall population. So we think it's nice that in these children with autism-related refractory seizure, we're seeing a nice response in these particular seizure types. Now, if we look at an efficacy responder analysis in the next slide, and we're going to capture this as either a 35% reduction or a 50% reduction. So these are thresholds. Did you get better by 35%? Did you get better by 50% in FIS and TCS? Let's take a look here. 35% responders by month 12 in the overall population, 89%. 50% responders in the overall population by month 12, 83%. And in the kids with comorbid ASD, again, it's a smaller number, but it's 75% of the kids are showing a 35% reduction. And again, 35% of the kids, rather 75% of the kids are showing a 50% reduction in seizures at the end of the study. Now, we also looked in the full population. We haven't yet pulled out the data for the kids with ASD because this is still sort of breaking news for us. We looked at sleep disturbance, and we all recognize that sleep is important for both the children and the families. And we showed important changes. So these are disorders of the initiation and maintenance of sleep on the left. Statistically significant 22% reduction in disorders of maintenance of sleep. We see a little bit of change in sleep disordered breathing. That's probably not clinically relevant. We're seeing fewer nightmares and arousals. This is sleep-wake transition disorder. So these are transitions in sleep. We're seeing improvement of 31%. Disorders of excessive somnolence. So this is next day sleepiness, reduction of 43%. Sleeper hyperhidrosis, which is sweating, goes down by about 11%, but that's probably not in a particularly meaningful range, but we're showing that anyway. And then overall, we're showing a 36% improvement in total sleep in this DEE population. So what about improvements in quality of life in these children? So when we look at the ELD-QOL, epilepsy and learning disabilities quality of life, we're seeing improvements in seizure severity, behavior, and mood with clinically relevant change in p-values that look encouraging to us. So to sum up what we saw in this BELIEVE study in children with DEE, and as well as in children with ASD who also qualify for the same diagnosis, overall, you can see important reductions in seizures. You can see those same important reductions in seizures in kids with ASD. You can look at reductions of 35 and 50% across the board in children with these seizure types, improvements in sleep, and then improvements in quality of life. So that's BELIEVE. Safety was also very good here. 30 serious adverse events in these very medically fragile children. There were 2 that may have been related to the study drug in the opinion of the investigator, lower respiratory tract infection and an episode of status epilepticus. We had 1 child who discontinued medication because he had redness on the skin, and this was a contact irritant complicated by a second bacterial infection. And again, in this study, as in the previous study, no changes in vital signs or ECGs, no changes that were clinically relevant. Only 1 child who had an increase in alkaline phosphatase, which may have been related to growth and not considered related to study medication. So conclusions: first trial of our drug in DEE, meaningful reductions in refractory seizures, clinically meaningful improvements in sleep, and a positive risk-benefit profile. The final study is our phase 3 study. This is against placebo. Lead author here is Elizabeth Berry-Kravis from Rush University Medical Center. FragileX, as you know, is a rare genetic disorder, prevalence of 1 in 4,000 males, 1 in 6,000 females, associated with a number of intellectual and emotional disabilities, including ASD, anxiety, and aggression, the most common cause of monogenic ASD, and there are no approved treatments for FragileX. FragileX is caused by a deficiency or absence of the FMR protein. This is typically caused by a trinucleotide repeat expansion of more than 200 CGG repeats in the promoter region of FMR1 that codes for FMRP. And FMR1 is located on the X chromosome. So this is a summation of what we learned in this particular study. In our primary endpoint, looking at social avoidance, we had a 40% mean percent change in socially avoidant behaviors in children with strong methylation of the FMR1 gene. When we look at clinician reported changes, there's a trend towards statistical significance. We see clinically meaningful improvements in behavior, in social avoidance, and irritability. And in the caregiver global impression of change, we see important changes in social interaction, irritability, social avoidance, and overall behavior. Overall, drug very well tolerated in ConnectFX. No serious or adverse events during the study. Again, this is double blind. All treatment-related events were mild or moderate. Most common TEAE was application site pain, and the laboratory values for chemistry, hematology were comparable between placebo and the ZYN002 groups, and no clinically relevant abnormalities in either group, and no clinically significant changes to any of the liver function tests. So this is, to our knowledge, the largest control study performed in FragileX in children with strong methylation of the FMR1 gene. ZYN002 was superior to placebo in multiple analyses, as you can see here. And we think these can be a step forward in the determination of biologically important constructs of pharmacologic response in FragileX. I'm just going to jump back and show one last slide that I think is important. So this is when we're talking to caregivers. Did your child get better? Social avoidance and isolation, irritable, disruptive behavior, social interactions, overall behaviors. And we're including here a little bit better, moderately better, and much better. And you can see across the board, strong statistically significant improvements and up to around 60% or more of patients on drug. So I will stop there.
That's great.
Cool. Thank you.
Wouldn't mind asking a question or two.
Sure, absolutely.
It seems like this is the same drug being used against 3 different audiences in all open label studies.
That's correct.
To say when you
open 2 open label and 1 placebo-controlled phase 3.
Which was the FragileX?
The FragileX study is a large 200 plus patient placebo-controlled study.
Yeah, and in terms of the p-values, you had a couple of p-values that were around 0.05 or not as spectacular as some of the p0001 values that you showed in, say, the first.
In the open label studies, we had very strong p-values. When we come to the larger phase 3 study, in which we then have to manage placebo response, we show good p-values, but you're right, they're not as spectacularly small. And again, the caveat is that this is in the children who have strong methylation of the FMR1 gene. We didn't hit a p-value in the overall population.
Yeah, and also there were a couple of reasonably good p-values for some of the sub-effects as well.
Yes, that's correct.
In FragileX, where it was much less than 0.0 or 1. So what's your hope in terms of getting to market first? Would you be going with the drug that you've already gone through the phase 3 with at this stage?
Right now, the primary driver of what we're going for next is making sure we can bring the FragileX program forward to FDA and to the market. And then we'll continue to develop the portfolio, the molecule in the portfolio.
How long obviously these things are many years in development, many times. What would you think is your likely time to market for the FragileX, given the phase 3 trial that you've just completed in a very small condition, the largest study ever done? I would think that would be faster to market than the other indications.
Yeah, we're still waiting to know exactly what FDA is thinking. We'll be able to announce that by the end of the year. And it will either be longer or shorter depending on the guidance we receive from FDA. We're happy with our data. We'll see if they share that excitement.
Yeah. And on the other, the ones that are more for either the seizure audience or the social interaction style, autism, nervousness, anxiety style. What was the name of the first trial? You said the Believe, Connect.
We have Bright and Believe and Connect FX. Yeah. So for those other studies, it's a little bit further away. We're a small 25-person company. We're prioritizing FragileX right now, and the others will follow. But they have right now been through phase 2. So you can imagine there are phase 3 studies to come.
Yeah. And for the parents in the audience that are, in some cases, working with CBD sort of over-the-counter things, there's nothing that they would be looking at before they would be able to get a prescription for this? Or is there anything that you are familiar with people working with?
So there is an oral drug that is approved for seizures that is CBD, and that is sold by a company called Biopharma. So that's an oral drug. We have a transdermal drug that gets the
Much
CBD
easier,
into the.
yeah.
So it's different, right? There are pros and cons, benefits up to both formulations, and I like the people at GW, and they're people that I know well who are there, and I don't see them as competitors. I see them as helping in a different way. So they've got a good drug. I think we've got a good drug as well. I think there are just benefits of what oral can give you and what transdermal can give you. Those drugs are, that company seems to be primarily directed at the moment towards seizure disorder. For both of these formulations, the GW formulation, our formulation, they are more potent than what typically you can get over the counter. So, by multiple factors. So, but if I had to guess, to get as much CBD into your body, especially the little body, versus what's over the counter, right? You would probably need to spend maybe $10,000, $20,000 per year out of pocket to get as much CBD somehow into your system versus what's available pharmacological. We're developing pharmacologically.
One last question about the transdermal
Yeah.
application. It would seem, I don't know the science behind this, but it would seem like that would be a longer lasting sort of period, or am I incorrect in that, rather than taking it orally? Like it would seem like the oral could actually sort of be quicker and shorter in duration, or how would
it's different. So we haven't run head to heads, right? So it's hard for me to say that, but in general, what you would expect with an oral drug is it goes into your system, it gets in quickly, and then is metabolized. With a transdermal, you have a different kinetic path. There's generally a little slower uptake, but also slower offset. So you're going to see waves with both, but one is going to have potentially higher waves, and this is blood levels, but that doesn't necessarily speak to total body levels.